You are the orthopedic registrar on call.
Right,
It's 2 a.m.
right.
You are standing in a frankly, harshly lit emergency department, and you're staring at a radiograph on the PSCS terminal.
A familiar scenario.
Very. And your heart rate immediately spikes because the image shows a posterior elbow dislocation. But here's the kicker. It's not just a dislocation.
No, it never is with this pattern.
Exactly. You see these associated just chaotic fracture lines running straight through the radial head and a jagged disruption of the coronoid process.
Yes.
And a cold sweat begins to form because you know exactly what you are looking at. You know you're not just looking at a broken arm, you are looking at a fundamentally destroyed joint envelope.
The architecture has completely failed.
Completely. And that's our focus for this deep dive.
It is genuinely the defining moment of an upper limb trauma call. I mean, that specific constellation of injuries, it represents the absolute definition of a catastrophic multiplanar failure of joint stability.
Catastrophic is the right word.
It is. It's the type of imaging that demands immediate, profound respect from anyone holding a scalpel. Because, well, frankly, if you underestimate it, the patient is guaranteed a lifetime of chronic pain and disability.
Which brings us to the dreaded terrible triad of the elbow.
Yes, the terrible triad.
Our mission in this deep dive is to take this notoriously complex and historically very poorly managed acute injury and transform it into a highly structured, predictable surgical algorithm for you.
We really have to move away from the old school trauma mentality of simply, fixing fractures.
Right, just pinning bone back together.
Exactly. We have to embrace a complete paradigm shift. We are here to talk about restoring profound dynamic stability to a shattered joint.
Okay, so let's unpack this. Why does this specific injury pattern command such infamy in orthopedic theaters?
Well, to understand the infamy, we really have to look at the historical context, and the sheer biomechanical devastation involved.
Going back to Hotchkiss.
Yes, when Hotchkiss originally described and popularized the term terrible triad, he was highlighting exactly why it is so terrifying for the surgeon.
Because everything goes at once.
Precisely. You suffer the simultaneous loss of the anterior buttress, which is the coronoid process. You lose the lateral column and the secondary bony stabilizer, the radial head.
And then the soft tissues.
Right. Crucially, you have profound disruption of the primary ligamentous restraints, specifically the lateral ulnar collateral ligament and very often the medial collateral ligament as well.
So you're left with nothing.
Literally nothing. The elbow is left with zero osseous architecture to resist subluxation and absolutely zero soft tissue tension to hold the joint congruent.
It is a total structural collapse. And understanding how to rebuild the elbow naturally begins with understanding precisely how it falls apart.
Pathoanatomy is everything here.
It is. Now, during my early training, I was always taught to compare the elbow joint to a three-legged stool.
Yes, the classic stool.
Right. The anterior osseous buttress, the lateral osseous column, and the ligamentous tension band. If you kick out one leg, it wobbles. Kick out all three, it collapses.
I mean, it's a very common analogy.
It is, but honestly, I think that is an incredibly cliche and basic analogy. It really doesn't capture the dynamic nature of the joint.
I tend to agree with you.
I prefer to think of it more like the mast of a sailboat.
That's a much better way to conceptualize it.
Right. The coronoid and the radial head are the deck and the mast step. They provide that solid compressive foundation, while the lateral and medial collateral ligaments are the structural rigging.
Holding the mast in perfect isometric tension.
Exactly. So if you shatter the deck and snap the rigging simultaneously, the entire mast just comes crashing down.
I much prefer the sailboat rigging analogy, because it captures the concept of isometry perfectly, which, we will discuss at length later.
You definitely will.
The three-legged stool implies a static, rigid structure, whereas the elbow relies on dynamic tension throughout a highly complex arc of motion.
It's constantly moving and constantly under variable load.
Exactly, and what's fascinating here is the sheer predictability of the destruction when you analyze the vectors of force that cause the triad.
So break that down for us. What is the exact biomechanical sequence of failure when a patient falls onto an outstretched hand? What is actually happening in those milliseconds of impact?
Well, the classic mechanism is a fall on an outstretched hand, but the precise positioning of the limb at the moment of impact is the critical variable.
It's not just a simple fall forward.
No, the forearm is typically supinated, the elbow is slightly flexed, usually around 20 to 30 degrees.
Right.
And in that specific position, the arm is subjected to a massive axial load combined with a valgus stress.
So as the patient's body weight drives the radius and ulna proximally against the distal humerus,
The valgus force places extreme tension on the medial structures and extreme compression on the lateral radiocapitellar joint.
and because the forearm is supinated, the entire soft tissue envelope is essentially wrung out like a wet towel,
That's a great visual.
twisting the joint violently out of its anatomical alignment.
And that rotational force is really the catalyst for the disaster. Sean O'Driscoll beautifully described this as a progressive circle of soft tissue failure.
And it progresses in a very specific direction, doesn't it?
It almost always progresses from lateral to medial.
Okay, so lateral first.
Yes. As the supination and valgus forces peak, the lateral ulnar collateral ligament fails first. It typically peels or avulses right off its origin on the lateral epicondyle.
So the lateral rigging snaps.
Exactly. And once that lateral rigging snaps, the radial head is completely free to subluxate posteriorly.
Which sets up the osseous collisions.
It does.
Because as the radial head is driven backward and proximally by that axial load, it shears violently against the capitellum.
And there is your radial head fracture.
Right. It's an impaction shear injury occurring while the joint is actively dislocating. It's not a direct blow from the outside.
No, it's a grinding, catastrophic internal collision.
Wow.
And the destruction accelerates from there. As the joint continues to subluxate posteriorly and rotate, the anterior capsule is pulled incredibly taut.
But that's still attached to the coronoid.
Yes, and the distal humerus drives directly into the coronoid process of the ulna.
So the trochlea essentially acts like a chisel.
A perfect description. It shears off the anterior buttress. And if the kinetic energy is high enough, the circle of failure continues completely medially, tearing the medial collateral ligament as well.
Leaving you with a completely stripped, multi-directionally unstable joint.
You're left with nothing holding it together. And treating these three injuries, the coronoid, the radial head, the ligaments in isolation, completely misses the broader context of the joint's compromised kinematic envelope.
Right, because you are not fixing three separate problems.
Not at all. You are repairing one shattered structural ring.
Which brings us perfectly to the preoperative reconnaissance phase.
The most important phase, arguably.
Because the injury is three-dimensional and involves such intricate interlocking joint surfaces, a plain radiograph is merely the alarm bell.
It tells you the house is on fire, but it doesn't show you the floor plan.
Exactly. But I want to challenge you on the real-world management here.
Okay.
So we are staring at this triad on the night shift. There is a massive temptation for a junior surgeon to rush this patient to theater immediately.
Oh, absolutely. The urge to act is strong.
Right, to get the joint reduced and fixed. But we are dealing with a massively swollen, traumatized limb. Are we actually doing the patient a disservice by opening them at 3 a.m.
Complete.
when the soft tissues are essentially a hemarthrosis soup? Or do we stabilize and wait?
That is an excellent clinical question, and it addresses a major pitfall in acute trauma management.
Because 3 a.m. surgery sounds heroic, but
Operating on a terrible triad at 3 a.m. is almost universally a mistake. Unless there is an irreducible dislocation with acute vascular compromise, that is the only real exception. Otherwise, the soft tissue envelope is incredibly hostile. The tissue planes are entirely obliterated by hemorrhage, and frankly, the surgical team is fatigued.
it's not the time for complex reconstruction.
Not at all. The modern consensus protocol dictates immediate closed reduction in the emergency department under sedation.
Get the joint back in place.
Yes, you reduce the joint, placed it in a well-molded posterior splint. Usually we put it in 90 degrees of flexion and neutral rotation.
To relax those soft tissues.
Exactly. And you elevate the limb.
Because we want that initial inflammatory phase to settle down. But, and there's always but we cannot wait too long, can we?
No, we cannot.
If you leave a triad in a splint for 2 weeks, the capsule contracts, the ligaments scar in completely the wrong functional position,
They do.
and then you are fighting a losing battle against profound stiffness before you even make your skin incision.
Or the sweet spot is typically between 3 to 7 days post-injury.
3 to 7 days.
Yes. This allows the acute hemarthrosis to resolve, making the surgical planes actually identifiable. But it is early enough that the capsule has not fibrosed.
And crucially, this delay gives you the time to acquire the absolute prerequisite for surgical planning.
The CT scan.
Exactly. A high-resolution computed tomography scan with three-dimensional reconstruction.
It's essential.
I want to push on that, though. A seasoned orthopedic consultant might argue, well, I have a good quality anteroposterior and lateral plane film. I can see the joint is dislocated, I can see the radial head is in pieces, and I know I need to fix it.
I hear that argument often.
Right. Why mandate a CT scan and delay the process?
I strongly refute the idea that plain films are sufficient for anyone tackling a terrible triad in the modern era.
Strong words, but fair.
A plain film confirms the diagnosis, yes, but it provides absolutely zero granular detail for your surgical strategy.
It's just a shadow.
Exactly. Plain films routinely underestimate the degree of comminution of the radial head. And more dangerously, they completely obscure the true morphology of the coronoid fracture.
Because of the overlap.
Right. Due to the complex, overlapping radiographic shadows of the proximal ulna and the radial head fragments.
Exactly. The lateral X-ray often just shows this vague, hazy piece of bone floating somewhere anterior to the joint line.
Yes, a little fleck of bone.
And you have absolutely no idea if it is a tiny capsular avulsion or a massive structural chunk of the anteromedial facet.
And your entire surgical strategy hinges entirely on understanding those precise fracture patterns.
The 3D recon is the map.
The CT scan allows us to apply the critical classifications that dictate our operative steps before the patient is even anesthetized.
Okay, let's walk through those classifications. Let's look at the lateral column first.
So for the lateral column, we utilize the Mason classification to assess the radial head.
Right.
A Mason type 1 is undisplaced. A type 2 is displaced but potentially repairable with screws or a small plate.
And a type 3.
A type 3 is highly committed, mechanically unviable, and completely irreparable.
So the CT scan tells you whether you are opening a microfragment set for a delicate little reconstruction, or whether you just need to send for the specific radial head arthroplasty trays and size templates.
Precisely. You know what implants you need before you scrub in.
Now, what about the coronoid? Because we used to rely heavily on the Reagan-Maury classification for the coronoid.
We did.
Which simply categorized fractures by the size of the fragment in the sagittal plane.
Yes. Type I was an avulsion of the tip. Type 2 involved 50% or less of the coronoid height. And type 3 involved more than 50%.
But that classification has aged really poorly, hasn't it?
It has.
Because it completely misses the biomechanical reality of the joint.
It is a classic example of an anatomical classification failing to account for biomechanical function.
Right.
O'Driscoll and his colleagues provided a monumental paradigm shift here.
They changed the game.
They absolutely did. They demonstrated that the anatomy of the coronoid is not just a simple two-dimensional triangular block. They highlighted the critical importance of the anteromedial facet.
And this is where the biomechanics become incredibly nuanced.
Yes.
Because the anteromedial facet is not just extra bone on the side.
No, not at all.
It is the specific insertion point for the anterior band of the medial collateral ligament.
Precisely. The O'Driscoll classification categorizes coronoid fractures into tip fractures, anteromedial facet fractures, and basal fractures.
So 3 distinct biomechanical zones.
Exactly. And a CT scan is absolutely mandatory to identify an anteromedial facet fracture.
Because if you miss it.
If you miss an anteromedial facet fracture on a plain film, which, as we discussed, is notoriously easy to do, and you fail to buttress it in theater,
What happens?
you leave the anterior band of the MCL completely incompetent.
Wow.
The patient will inevitably develop insidious varus posteromedial rotatory instability.
So every time they move?
They will feel their elbow clunking and subluxating every time they try to push up from a chair.
That's a disaster.
It is. The CT scan is not a luxury. It is the definitive map of the battlefield.
Okay, so we have our 3D map. The swelling has subsided, and we are finally wheeling the patient into theater.
Yes, day 5 or 6, let's say.
We are drawing heavily on the highly structured algorithms established by David Ring, George Athwal, and the Pugh protocol.
The Pugh protocol is fantastic.
And any complex reconstruction must start with the foundation. We must establish the architectural keystone of the elbow.
And the coronoid process is undeniably the keystone.
It's the front door stopper.
It acts as the primary anterior bony buttress, preventing posterior translation of the ulna beneath the distal humerus. Without an intact coronoid, the distal humerus simply slides off the back of the ulnar diaphysis the moment you bring the elbow into extension.
It just falls out the back. So how do we conquer the coronoid in theater? Because historically, small fragments were often just debrided and thrown away in the bin to prevent loose bodies in the joint.
Yes, they were. And that historical practice resulted in thousands of chronically unstable elbows. The cardinal rule and error this is a crucial clinical pearl for the listeners, is that even tiny coronoid fragments must be addressed in the context of a triad.
Even the tiniest flick.
Even the tiniest flick, because in an isolated injury, sure, a tiny tip avulsion might be managed non-operatively, but in a triad, that tiny tip represents the avulsed anterior capsule.
Oh, I see.
If you do not secure it, you leave the anterior tension band completely incompetent. You must meticulously reconstruct it.
Let's get into the granular details of the surgical approach then, because accessing this keystone is a nightmare.
It is not for the faint of heart.
It sits deep in the antecubital fossa. It's surrounded by the brachial artery, the median nerve, and a dense layer of flexor musculature.
Real estate is very tight.
How are you actually getting eyes on this without destroying more tissue? Because I have always found the debate between the Kaplan interval and the Kocher interval really fascinating here.
It is one of the classic debates in upper limb trauma.
Let's break it down.
In the vast majority of terrible triad injuries, you can address all three lateral and anterior components through a single extended lateral approach.
Right.
The Kocher approach utilizes the internervous plane between the anconeus, which is supplied by the radial nerve, and the extensor carpi ulnaris, supplied by the posterior interosseous nerve.
So you're going between the nerves.
Yes. It provides excellent safe exposure of the lateral compartment.
But, and this is the issue with the Kocher, it requires you to essentially look around the corner of the proximal radial nerve joint to see the coronoid, doesn't it?
It does. It's an oblique view.
Some surgeons prefer the Kaplan interval, going between the extensor digitorum communis and the extensor carpi radialis brevis, because that provides a much more direct, straight-on view of the anterior coronoid.
That is absolutely true. The Kaplan interval does provide a more anterior trajectory.
Yeah.
However, the critical trade-off is the posterior interosseous nerve.
The pin.
The pin crosses directly through the operative field in the Kaplan approach. And in a severely traumatized swollen elbow, where the normal anatomical landmarks are completely distorted, the risk of a disastrous iatrogenic pin palsy is significantly higher.
You definitely do not want to give them a drop finger.
Exactly. Therefore, most trauma surgeons default to the Kocher approach.
Better safe than sorry.
Quite. And once you open the capsule via the Kocher interval, you are immediately confronted with the fractured radial head.
And you actually use that fractured radial head to your advantage.
You do.
It is essentially a natural window. If the radial head is comminuted in irreparable, a Mason III, you excise those shattered fragments.
You take them out to prep the bed.
Right. And suddenly, you have a large empty window looking straight across the joint at the coronoid process.
It gives you fantastic visualization.
So you can prepare the fracture bed, clear out the hematoma, and execute your fixation right through that lateral window.
That is the elegant part of the procedure. But the specific fixation technique depends entirely on the O'Driscoll morphology we identified on the CT scan earlier.
Right, so let's talk about the small transverse tip fractures first. The O'Driscoll type I.
Okay.
These are way too small for a screw. How do you hold a fragment that is often no larger than a baked bean?
Well, we use the suture lasso technique.
And this requires real finesse.
Real finesse. You cannot just blindly throw stitches into the dark.
Yeah.
You pass heavy, non-absorbable #2 high-strength sutures through the thick anterior capsule right at the junction of the bony fragment.
And we often use a specific suture passer or a curved spinal needle to retrieve those limbs.
Yes. And then you drill 2 parallel transosseous tunnels from the anterior fracture bed, exiting out the dorsal aspect of the proximal ulna.
Which is the bare area.
Yes, the bare area where the hardware or knots, in this case, will not irritate the subcutaneous tissues.
And the tactile feedback during this step is critical, isn't it?
Oh, completely.
You shuttle those suture limbs through the drill holes. As you pull tension on the sutures from the dorsal ulna, you can literally watch the anterior capsule and that tiny bone fragment parachute down into the fracture bed.
It's very satisfying to watch. It perfectly restores the anterior buttress.
And tying those sutures down securely reduces the fragment and heavily retensions that anterior capsule.
That's the suture lasso. But what about the larger basal fragments, the O'Driscoll type 3 injuries, where a massive chunk of the ulnar metaphysis has sheared off?
Right, the suture lasso isn't going to hold that.
No, for substantial basal fragments, the suture lasso is biomechanically insufficient. We must escalate the fixation to rigid osteosynthesis.
Plates and screws.
Yes. We might use cannulated headless compression screws passed from posterior to anterior through the intact ulna to capture the fragment. Or, increasingly, we use small, pre-contoured mini fragment buttress plates applied directly to the anterior surface of the coronoid.
But here's the trap, and I want you to highlight this for our listeners.
Okay.
What about the anteromedial facet fractures we discussed earlier? Can you reach those through the lateral cocher window?
No, that is a critical limitation and a classic pitfall.
You just can't get there.
You cannot adequately visualize, reduce, or plate an anteromedial facet fragment from the lateral side. The trajectory is entirely wrong.
It's mechanically impossible.
It is. If the preoperative CT scan dictates that the anteromedial facet is involved, you must make a separate medial incision.
You have to flip your perspective entirely.
You do. You typically identify the medial epicondyle, protect the ulnar nerve, and then either split the flexor carpial maris or elevate the pronator mass to expose the sublime tubercle and the anteromedial facet. You must place a specific, contoured anteromedial buttress plate to hold that fragment. And, by extension, the medial collateral ligament.
Right, because if you don't.
Failing to recognize the need for that second, medial approach leaves the joint chronically unstable.
Okay, so the anterior foundation is secured, the coronoid is buttressed, the capsule is tensioned. The focus now shifts to the lateral column,
The radial head.
which bears the absolute brunt of the valgus load during upper limb weight bearing. Now, in an isolated, highly comminuted radial head fracture in, say, a low-demand elderly patient, we might occasionally just excise the shattered bone, wash out the joint, and accept a mild biomechanical deficit.
We might.
Why is that an absolute never event in the context of a terrible triad?
It is an ever event because of the cascading failure we outlined earlier.
Circle of failure.
Exactly. To understand why, we have to look at how the medial and lateral structures interact.
Right.
In a pristine, intact elbow, the medial collateral ligament is the primary absolute restraint to valgus stress.
It does the heavy lifting.
It does. The radial head articulating with the capitellum is merely the secondary restraint. It provides roughly 30% of the resistance.
Okay.
However, in a terrible triad, the medial collateral ligament is almost always compromised.
It's a torn.
It is either plastically deformed and stretched, or frankly avulsed.
Which means the secondary stabilizer suddenly becomes the primary stabilizer.
Yes.
The radial head is the only structure left preventing the elbow from collapsing into valgus.
Exactly, the mechanical reality. If you excise the radial head in the presence of an incompetent medial collateral ligament, there is literally nothing resisting valgus force.
Wow. So the moment the patient attempts to push open a door or lift a kettle?
The elbow will hinge open on the medial side. The radial shaft will migrate proximally, leading to catastrophic multiplanar instability.
Chronic ulnar nerve traction neuropathy.
Yes, and rapid, devastating arthritic degeneration of the ulnohumeral joint.
So no excisions.
The golden rule of triad management is definitive and unyielding. Never excise the radial head.
You must restore the lateral column. If it is a simple, large 2-part or 3-part fracture, you meticulously reconstruct it on the back table with headless compression screws or a low-profile plate, ensuring perfectly flush articular margins.
Yes, fix it if you can.
But if it is heavily comminuted, a true Mason type 3, where the cartilage is just pulverized, you must replace it with a metallic radial head arthroplasty.
Let's delve into the deep nuances of radial head arthroplasty, because it is certainly not as simple as hammering a metal spacer down the radial shaft.
No, it's not a carpentry exercise.
The early generations of implants, like the silastic radial heads, were disastrous because they fragmented under load and caused massive silicone synovitis.
And even modern metallic implants are highly technique dependent.
Very much so.
What are the critical technical factors the surgeon must control to ensure the arthroplasty restores native kinematics rather than destroying them?
Well, sizing is absolutely everything.
Getting the diameter right.
Yes. The native radial head is a fascinating piece of anatomy. It is not a perfect cylinder. It is a complex elliptical structure with a specific articular dish depth that mates perfectly with the convexity of the capitellum.
It's a very specific puzzle piece.
If you insert a radial head prosthesis that is too large in diameter, it will mechanically impinge on the lesser sigmoid notch of the proximal radial Marner joint.
And the clinical result of that is a complete mechanical block to forearm pronation and supination. The patient will have a stable elbow, but they cannot turn a key or use a screwdriver.
Exactly. But an even more dangerous error is what we call overstuffing the joint.
Right.
What happens if the prosthesis is too long? It is incredibly easy to do because surgeons often try to reconstruct the shattered fragments of the native head on the back table to measure the height.
Which seems logical.
It does, but they're often missing several millimeters of impacted bone, so the measurement is wrong.
Overstuffing is a devastating technical error. If the neck of the prosthesis is even 2 or 3 millimeters too long, it acts like a jack.
Yes.
It violently jacks the joint open laterally.
And this does two catastrophic things. First, it places immense unnatural tension on the lateral ligaments you're trying to repair.
Virtually guaranteeing they will fail or stretch out over time.
Yes. And second, it drives the metallic head into the capitellar cartilage with massive unphysiological force.
So over the course of a few months, this causes rapid, abrasive capitellar wear.
Essentially grinding away the cartilage until bone rubs on metal.
And the patient presents with severe pain and significant mechanical restrictions in both flexion and extension.
It's awful.
So how do we avoid it? We must use the uninjured contralateral elbow x-rays as a preoperative template to gauge the native height.
Yes, contralateral templating is key.
And intraoperatively, there is a specific anatomical landmark we use, isn't there?
There is. The articular surface of your prosthesis must sit precisely level with the lateral edge of the lesser sigmoid notch of the ulna.
So you run your finger across it.
Yes. If it sits proud of that notch, you have overstuffed the joint and you must downsize the implant.
That is the definitive intraoperative check. So we have rebuilt the bone, the coronoid is fixed, the radial head is replaced, the osseous scaffolding is completely restored.
Excellent.
But bone is just the scaffolding. The ligaments provide the dynamic tension that keeps the joint congruent. We must address the soft tissue envelope.
Following the Pew protocol, once the osseous constraints are rigidly fixed, we must move to the lateral ulnar collateral ligament.
The LUCL.
Yes. The LUCL is the primary restraint to posterolateral rotatory instability. It anchors the lateral aspect of the ulna to the humerus, acting exactly like the tensioned rigging on our sailboat mast.
And during a triad dislocation, that entire lateral musculoligamentous complex is typically avulsed right off its origin on the lateral epicondyle.
It peels off like a sleeve.
Just strips right down.
It does. To repair it, we use heavy, non-absorbable sutures passed through bone tunnels or modern suture anchors.
But the absolute critical concept here, the concept that determines the success or failure of the entire operation, is isometry.
Yes, we touched on this earlier. Isometry means the ligament maintains a constant length and tension throughout the entire arc of motion.
It can't be tight here and loose there.
Exactly. The LUCL must be tensioned correctly to the precise isometric footprint on the lateral epicondyle.
And where is that exactly?
This point is located exactly at the anatomical axis of rotation of the capitellum.
So if you place your suture anchor too anteriorly on the epicondyle, the ligament will be incredibly tight in flexion.
Which blocks the patient from bending their arm.
Right. And it will be completely lax and useless in extension, allowing the joint to subluxate.
Precisely. Conversely, if you place it too posteriorly, it will be tight in extension and loose in flexion.
It must maintain constant functional tension from full extension to full flexion.
How do we confirm that in theater?
Well, I have always placed my suture anchor, passed my sutures through the ligament, and then held the suture limbs under tension with a clamp while taking the elbow through an arc of motion.
Yes, the dynamic test.
Right. If the clamp moves or the sutures toggle back and forth, I know I am not on the isometric point and I need to reposition my anchor.
That is the exact correct technique. You must dynamically test the isometry before you permanently tie the knots.
Okay, let me put you in a practical scenario, Professor.
Go on.
You are in theater. You have perfectly fixed the coronoid. You have meticulously sized and implanted the radial head arthroplasty. No overstuffing. You have anatomically repaired the LUCL to the exact isometric footprint on the lateral epicondyle. The lateral side is completely buttoned up.
Excellent.
The moment of truth arrives. You bring in the image intensifier. You take the elbow through a full, slow range of motion under live fluoroscopy.
The stress test.
What exactly are you looking for, and what happens if the elbow still drops out the back?
Well, this is, without question, the most anxiety-inducing moment of the entire operation.
Heart and mouth.
Oh, absolutely. You have spent 3 hours reconstructing the anatomy, and now you must test the physics.
Right.
You are looking for perfect concentric reduction of the ulnohumeral joint through the entire arc of motion.
So how do you maneuver the arm?
You start with the elbow flexed at 90 degrees, where the bony congruency makes it most stable, And you slowly extend the arm while applying a gravity stress.
Just letting the weight of the forearm pull down.
Exactly.
Yeah.
If the joint remains perfectly congruent until terminal extension, you have succeeded. The architecture holds.
But what if, as you reach 30 degrees of extension, you see on the fluoroscopy monitor that the ulnohumeral joint begins to widen, and the ulna starts to subluxate posteriorly away from the humerus?
The dreaded dropout.
It is a terrible feeling.
It is demoralizing, but
Yeah.
you must trust your algorithm.
Right. Don't panic.
Exactly. If the elbow remains unstable in extension despite perfect anterior and lateral reconstruction, you have a residual medial-sided problem.
The algorithm dictates your next move.
It does. You cannot rely on a postoperative brace to hold it.
Oh, definitely not.
You must flip the patient's arm, prep the medial side, make a medial incision over the medial epicondyle, and explore the medial collateral ligament.
Usually we find that the anterior band of the MCL is completely avulsed off the sublime tubercle, or the medial epicondyle.
Yes, and we repair it using suture anchors, similar to the lateral side, ensuring strict adherence to the medial isometric point.
And then you test it again.
You test it again.
But let us take the scenario to its absolute extreme. What if you repair the MCL, you check the fluoroscopy again, and the joint still subluxates? Or what if the initial injury was such high-energy trauma, a high-speed motorcycle accident, for example, that the soft tissue envelope is completely macerated?
Shredded.
Yes, shredded like wet tissue paper, and simply will not hold tension no matter how many anchors you use.
In that extreme nightmare scenario where the soft tissues are completely destroyed and cannot maintain concentric reduction despite your absolute best reconstructive efforts, you have to deploy the ultimate salvage for acute instability.
The hinged external fixator.
The hinged external fixator. It is essentially a robust metallic exoskeleton.
It forces the joint to remain reduced.
It does. You place heavy hive pins into the lateral humeral diaphysis and the subcutaneous crust of the ulnar diaphysis, but the fixator is only as good as its hinge.
This is critical.
Crucially, the hinge of the external fixator must be perfectly aligned with the true anatomical axis of rotation of the native elbow.
Which is a line that passes straight through the center of the capitellum laterally and the anterior-inferior aspect of the medial epicondyle medially.
Finding that axis requires driving a 2mm K-wire straight through the humerus under fluoroscopic guidance to act as the guide for the hinge.
It demands absolute precision.
Absolute. If you mismatch the axis of the external fixator with the axis of the native joint by even a few millimeters, the fixator will actively pry the joint apart.
Grinding the cartilage to dust every time the patient flexes or extends their arm.
Which is why the external fixator is reserved only for true salvage.
Right.
But when applied perfectly, aligning the mechanical hinge with the anatomical hinge, the external fixator is a lifesaver.
It holds the joint rigidly reduced while still allowing the patient to perform early, active flexion and extension.
Yes. It acts as an internal splint, protecting your tenuous, fragile ligament repairs from shear stress while they heal over the next 6 weeks.
Which transitions us perfectly into the final phase of management. A beautifully executed surgery, perfect implants, and even a flawlessly aligned external fixator can still yield a devastating functional outcome if the postoperative rehabilitation strategy is flawed.
Rehab is make or break.
The surgeon and the patient must navigate a very narrow, very dangerous tightrope between two competing evils: stiffness and instability.
Yes.
Historically, we failed patients in this regard. These injured elbows were casted in plaster at 90 degrees for 6 solid weeks to ensure the ligaments healed.
Awful practice.
The result was often a perfectly stable but permanently frozen, non-functional joint. They couldn't feed themselves or wash their face. How do modern protocols balance the biological necessity of ligamentous healing with the biomechanical necessity of movement?
Modern postoperative reality requires a very frank conversation with the patient, grounded in hard clinical truths.
Managing expectations from day one.
Exactly. This is largely borne out by the extensive research of David Ring, George Athwal, and others who track long-term outcomes.
And what do they tell us?
The clinical truth is this. Profound stiffness is the most common complication of a terrible triad injury. However, stiffness is vastly preferable to recurrent instability.
Stability must be prioritized first, above all else.
It is the lesser of two evils.
Absolutely. A stiff elbow can often be addressed later. If a patient heals with a stable joint but a severe contracture, we can take them back to theater 6 months later.
Yes, perform an open or arthroscopic capsulectomy to release the scar tissue and regain motion.
But a chronically unstable subluxating elbow is a ticking time bomb.
It will rapidly destroy the articular cartilage, leading to catastrophic post-traumatic osteoarthritis,
And in a 30-year-old patient, that requires a total elbow replacement.
which comes with massive lifetime restrictions and high failure rates. It is an unmitigated disaster.
So we accept a certain degree of stiffness as the required price of admission for a stable joint. We tell the patient, you will likely lose the last 20 degrees of extension to the rest of your life.
You have to be honest with them.
But we still aim for motion to nourish the cartilage. How early is early active motion, and what are the strict parameters?
If our intraoperative fluoroscopy demonstrates that the elbow is concentrically stable after our reconstruction, we initiate early active motion incredibly early,
How early?
usually within the first 3 to 5 days post-operation. But there is a massive caveat.
What's that?
We strictly forbid passive stretching.
This is vital for physios to understand.
Completely vital.
Passive stretching, where someone else forces the joint to bend, incites severe inflammation, micro-tearing of the healing ligaments, and triggers a massive ectopic bone formation response.
Yes, we rely entirely on the patient's own active muscle contraction.
Because active muscle contraction is biomechanically protective. As the triceps and brachialis contract to move the arm, they actively compress the joint surfaces together.
Enhancing the stability of the ulnohumeral articulation.
Right, they act as dynamic muscular stabilizers.
We typically use a hinged dial-in brace to protect the joint from varus and valgus stress, and we determine the safe arc of motion based directly on our intraoperative fluoroscopy findings.
So we customize the rehab to the individual's anatomy.
Exactly.
If we notice that the elbow tended to subluxate at 20 degrees of extension while testing it in theater, we set the extension block on the postoperative brace to 30 degrees.
We give ourselves a buffer.
We allow full flexion to stretch the posterior capsule, but we protect the terminal extension, which is the most vulnerable position where the coronoid is maximally stressed for the first few winks.
Gradually opening the dial 10 degrees a week as the soft tissues scar in and heal.
We must also address one final major biological complication that plagues severe elbow trauma, and that is heterotopic ossification, or HO.
A huge problem.
The elbow seems uniquely and aggressively predisposed to forming rogue ectopic bone in the surrounding soft tissues after a catastrophic injury like the triad.
It is fascinating, really. The elbow capsule and the surrounding flexor pronator musculature react violently to high-energy trauma, hematoma, and extensive surgical dissection.
And the exact pathophysiology is incredibly complex.
Very.
But it essentially involves circulating mesenchymal stem cells, migrating into the traumatized muscle, and differentiating into osteoblasts, laying down bone where there should only be muscle and tendon.
Yes. In severe triad injuries, particularly those associated with concurrent traumatic brain injuries or massive soft tissue stripping,
What happens?
heterotopic ossification can become so severe that it completely bridges the joint, creating a solid, extra-articular bony ankylosing.
The joint literally fuses itself solid.
Which brings up the current, often contentious stance on prophylaxis. How do we prevent this rogue bone formation?
It is an area of intense debate in the literature. In high-risk patients, those with massive trauma, head injuries, or delayed surgery, we often employ aggressive prophylactic measures.
Medication-based.
Right. This typically involves a short, targeted course of nonsteroidal anti-inflammatory drugs. Specifically, indomedacin, given for 3 to 6 weeks, has been shown to effectively inhibit the prostaglandin pathways that trigger the osteoprogenitor cells.
Or, in highly selected, extremely high-risk cases, we might utilize a single, targeted dose of low-fraction perioperative radiotherapy.
Usually around 7 gray.
Yes, administered within the first 72 hours. The radiation effectively sterilizes their rapidly dividing osteoprogenitor cells in the soft tissues without significantly compromising the bone healing of the fractures themselves.
Wow. This has been an incredibly dense, highly structured masterclass in managing an injury that genuinely frightens most clinicians, from the 2 AM X-ray to the 6-month rehab milestone.
It's a lot to take in, but a systematic approach is key.
Let's synthesize this deep dive into core, memorable clinical pearls for the listener who might face this exact scenario tonight. First, the coronoid is the absolute keystone of the joint. You must respect, address, and repair even the smallest fragments because they represent the critical anterior capsule tension band. Do not throw them away.
Never.
Second, the golden, unyielding rule of the lateral column. Never, ever excise a radial head in a terrible triad. You must either achieve perfect anatomical reconstruction or proceed to a meticulously sized, non-overstuffed arthroplasty.
Third, you must implicitly trust your intraoperative fluoroscopy. The surgical sequence is not a rigid list. It is a dynamic algorithm guided by live testing.
Right.
Fix the anterior foundation and the lateral structures, then test the stability against gravity. If it fails, move medially and address the MCL.
And if it still fails?
Deploy the hinged external fixator on the exact anatomical axis. Do not leave the theater hoping a bulky dressing or a plastic brace will hold a subluxating joint. It will not.
And finally, navigating the rehabilitation tightrope. Accept that some permanent loss of terminal extension is highly likely and communicate that expectation to the patient very early in the process. Accept some degree of stiffness to guarantee stability because a chronically unstable elbow is an unsalvageable, life-altering disaster.
This entire discussion raises an important, provocative question for the future of our specialty.
Oh.
Right now, we spend hours in theater meticulously piecing together shattered coronoids with microsutures and fine-tuning off-the-shelf modular radial head prostheses.
It's reactive carpentry, really.
Exactly. As our three-dimensional printing capabilities, biological scaffolding, and custom patient-specific arthroplasty technologies evolve at an exponential rate, will we eventually move away from attempting to osteosynthesize these microscopic, devascularized fragments?
That's a fascinating thought.
Will the future of managing catastrophic injuries like the Terrible Triad rely on immediate, patient-specific, biologically integrated joint resurfacing engineered precisely to the patient's uninjured contralateral anatomy?
It is a profound paradigm shift to consider, moving from microscopic reactive carpentry to bespoke, proactive biomechanical engineering. We leave you with that thought to ponder as you look at your next trauma CT scan. If today's step-by-step breakdown has given you a clearer blueprint for your next complex upper limb case, please take a moment to rate the show and share it with a colleague who might find themselves staring at a terrible triad on their next night shift. Until next time, keep scrutinizing the imaging, keep challenging the consensus, and keep diving deep.